Good morning. This is from Madras Medical Mission, Chennai. I am Dr. Shivakumar, heading the Pediatric Cardiology Division, and with me is Dr. Tejasvi, who is our Senior Fellow. Dr. Pramod Sagar, who is the consultant, will be presenting a short detail about this patient who has got a very interesting clinical situation. Over to you, Dr. Pramod.
Yeah. Welcome everyone. Our patient is a 4-year-old boy. He is a known case of transposition of great arteries with a small destructive VSD, ASD and a large PDA, who was diagnosed at birth and was on prostaglandin infusion to maintain the patency of PDA for duct-dependent circulation. Then he underwent a arterial switch operation at day 7 of life.
PARV.
During the surgery,
PARV.
as you can see here, the aorta and PA, the aorta was arising from the anterior RV and PA from the posterior LV, so the aorta and PA were transected, and the PA was brought forward to anastomose into the RV by a Lecomte maneuver. That is, the PA was brought anterior so that the aorta can be pushed posterior, and the aorta was then anastomosed into the LV. This is how a Lecomte maneuver is done. So the PA will be anterior and the branch PAs will go by the side of the aorta before reaching the hilum. So the patient was doing well, and on routine clinical follow-up, he was doing well, but the examination showed there was a grade 3/6 ejection systolic murmur in the left upper sternal border, which was significant and it was progressing. This is the ECG, which shows normal sinus rhythm with an axis of +90 with prominent right ventricular forces. This is an X-ray which is not much remarkable. There is a mild RA enlargement. There is no significant cardiomegaly. CTR is at 55%. Otherwise, nothing major in the X-ray. Echocardiography. If I have to tell about the echocardiography in a patient with arterial switch with a patient who has undergone arterial switch operation after post-Lecomte, the imaging of the branch pulmonary artery becomes difficult. Here we can see that this is a frozen image. This is the aorta and this is the anterior MPA, and this is the origin of the branch PAs, but it's difficult to image because it is completely anterior and they are difficult to image by echocardiography alone. However, we could find that there was a gradient of 80 millimeter across LPA and 70 across RPA by echocardiography. So we did a CT. This is a CT which shows the Lecomte. This is the anterior MPA. This is the posterior aorta. This is the RPA and this is the LPA. We can see that the RPA has significant narrowing where at the point of contact with aorta, and also the LPA has significant narrowing here. The hilar RPA is good sized and the hilar LPA is marginally smaller. However, the narrowing was quite significant, and RPA narrowing was around 3 and LPA was around 4 millimeter. This is the reconstruction which shows better actually. This is the anterior MPA and this is the branching of the MPA into left pulmonary artery and the right pulmonary artery, and this is the posterior aorta. This is the anatomy after a Lecomte, where we can see that the MPA divides and the RPA and LPA will go by the side of the aorta. When we slice it, we can see here that the MPA bifurcation is fine, but as the RPA origin begins, there is narrowing that begins from the RPA slowly, and the RPA is significantly narrowed here. However, the RPA hilum is good in size. Again, LPA, if we see, LPA is again narrowed in the whole length, and this is the hilum. So this is like a virtual stenting, how it can be done. Like the plan is to, like virtually we stented both the branch PAs, and if we stent it, we will see that the stents will be not in contact with each other, both are a bit far from each other, and we will be able to achieve a good relief of obstruction. The branch PA stenosis after this arterial switch operation is a common complication that is known and varies from studies, and it vary from 7 to 40%. And this is one of our patients who is presenting now with branch PA stenosis, who is having increased RV pressures. So we have taken him for an intervention.
We did a little bit of preliminary work. We took a right femoral venous, right femoral arterial axis, and left femoral venous axis. There are two venous axes that has been taken in order to facilitate bilateral pulmonary artery stenting, so that one sheath will take care of the right and one for the left. And there was a doubt about a small residual ventricular septal defect, and hence we have taken an arterial line. So the arterial line is also in place for us to do an elective left ventricular angiogram if there is a need. What we did was advance a catheter from the right atrium into the right ventricle and the branch pulmonary arteries. I'll show you the fluoroscopic image. So we have now two catheters. The right femoral sheath has got an 8 French sheath that is running in the right ventricle. And from the right ventricle, there is a marker pigtail that has gone deep into the right pulmonary artery. And in the pressure tracing, what we see is the right ventricular pressure of around 85 to 90 millimeters of mercury. And the pulmonary artery pressure is somewhere around 30 to 35 millimeters of mercury. So there is a significant gradient between the right ventricle to the right pulmonary artery. The pigtail catheter is deep in the right pulmonary artery. Angiogram, we have positioned our catheter across the right. I'm going to withdraw the right pulmonary artery pigtail and probably give an angiogram.
The view, what is the view you are choosing for angiograms in this case, sir? In a patient with LeCompte like this, what is the better view?
Yeah. So the basic the pulmonary artery here will be coursing from anterior to posterior, as well from the midline towards the right. So we'll give a right anterior oblique for the right pulmonary artery and left anterior oblique for the left pulmonary artery. The marker is there to guide us little bit more. Yeah, that's enough. That's enough. To collimate a little bit. Nicely collimate. Yeah. So what's the weight of this patient? 25. Yeah, 15 ml at 15 rate should be sufficient. Let's see this picture for the right. We will measure the right, and then we will probably introduce this marker pigtail onto the left and make another angiogram. Are we ready for the angiogram? 15 ml at 15 ml per second rate and around 1000 psi. Ready? So it's quite a significant narrowing, and we can find that a lot of the contrast is actually going distally. Freeze the image and show the narrowing. Yeah, so that's the narrowing. I'm going to do advance the catheter into the right pulmonary artery, advance my sheath and make an angiogram here through the sheath with my hand. So if you look at it from the marker, we have 3 markers across the entire length of the right pulmonary artery. So probably the length of the stent needs to be somewhere around 30 millimeter. Do you agree?
Yes, sir.
And then let us make some measurements about what is the size of the hilar pulmonary artery as well as the mediastinal pulmonary artery. It is the proximal 15 millimeter that is significantly narrowed. So we will have a look at it. So right now what we'll do is, let us get the Terumo wire. We'll go deep into the right lung. Come to AP projection, please. So I'm taking out this marker pigtail. I want the right coronary artery catheter next. Basically an end hole diagnostic catheter to go deeper into the right pulmonary artery. I have gone with the 4 French Judkins right coronary catheter. Hold the wire. So now at this point, we'll change into an amplat superstiff guide wire. So this amplat superstiff guide wire will be our workhorse for the stent angioplasty. Once I position the catheters, then we will take some measurements and then take a decision about already it looks like the length of the stent needs to be about 3 centimeters. We need to decide about the diameter of the stent.
Yeah.
Can you freeze it? Okay. Okay. I think we have a reasonably good quality image. It looks like the left pulmonary artery may need even longer stent. It may need almost like 4 centimeter. Let's make some measurements. We are able to appreciate that the markers are 3 full markers are there across the entire right pulmonary artery. So we need a stent that is about 3 centimeters on the right and which can be dilated, which can go up to say around 10 or 10 millimeter. The options for us are trying out a cobalt chromium stent which we have to mount on a balloon, or we can use a pre-mounted formula, Cook formula 1030, deploy it and then post dilate to around 12. I think we'll go for the second option, a pre-mounted stent, and then go for a longer option. Let me first get the stents deeper into the pulmonary artery. So now I'm having the right pulmonary artery stent.
Sheath. Planning to advance the sheath.
Advance the sheath. So we've gone across the right pulmonary artery, holding the sheath. And similarly, I'll make an advance into the left pulmonary artery. Can we go to that right pulmonary artery projection so that the position seems fine. So you can slowly start inflating.
I'm starting to inflate now.
Yeah. Yeah, keep inflating. Keep inflating.
Yeah.
Go up to
we're
10 to 11
atmosphere, 10 atmosphere, and 11 atmosphere.
Now we can deflate. Fluorostore this and show us again. So this is the expansion sequence. So our proximal end of the stent is remaining proximal to that metallic marker throughout. Yeah. So let us see the position now. So the right balloon comes out. Holding the wire. Okay, so now let us concentrate on the left. Shall we go to the LAO projection? Let's look at the left pulmonary artery measurements, Pramod. Left pulmonary artery measurements. Yeah, correct. I think here. Yeah. See here, if you see that, it's a long course. See, from the beginning,
4.
it's almost, yeah, more than 3 to 4.
3 to 4. So we go for a 10 into 4 centimeter stent.
I'm thinking about it.
The length is probably again wrong here. Like when we see.
Yeah.
Uh,
Can you show the angiogram again? Yeah. See the. Can you freeze the image and show? Go back a couple of frames. Correct. Next frame. Correct. So here, if you see,
again 4 markers.
It's almost
3.5, more than 3.5 markers.
So I'm considering about. Shall we consider a 10 into 4 here?
10 into 4 should be fine.
10 into 4 because the length. Just empty the contrast. Let us see the number of holes. Yeah. Now you start going onward. Okay. Next frame. Enough. So here it's 1, 2, 3. Yeah, definitely. It looks like almost 4. We have to capture that LPA origin as well. The LPA origin is now in this frame exactly below the first sternal wire and above the sheath tip. Can you see that?
Yes, sir.
So from that point onwards, we have to capture it. I'm going to peel back the sheath. It's going a little deeper. I will come again on pressure guidance. So I'm connecting the left pulmonary artery sheath to pressure. So we are recording low pressures now. It indicates that we are still not opened out the stenosis. So now I'm coming. We are beginning to have higher pressure recording. So proximally, I will expose the I have now exposed the last strut. I think we are ready to go.
Yes, sir.
Keep going.
Okay, I'm inflating.
Yeah, just go rotation.
Yes, sir.
Yeah. Go to 10 or 12 atmospheres.
10 atmosphere now.
11.
11, 12.
Okay, now deflate. Since we have decided to post dilate this, let's get a 12 into 2 Mustang ready. It's fully deflated.
Fully deflated.
So can you hold it? I'm again putting in the sheath inside. Oh, the stent is moving. Once again. Let's. Can we see whether show the previous picture? The previous. Did we record the inflation? Okay. So at this point, the stent is actually flush with the other pulmonary artery. So can you hold the wire? It's fully negative, this balloon?
Fully negative.
Okay.
No, it is possibly there only.
No, proximally it has moved more distally.